Hi everyone, this is Dr. Venkatesh Karthikeyan, Community and Family Medicine Postgraduate Resident from AIIMS Patna. So, we all know as clinicians how important is a good doctor-patient relationship, how important it is to have a good rapport with our patients. But in recent days, this doctor-patient relationship is not smooth. So, in order to emphasize about the importance of doctor-patient relationship and what are the factors which influence the doctor-patient relationship and how can we improve this, we are having this session. So, in this session, we'll be briefing about why this topic of doctor-patient relationship is important. What are the patient-related factors? What are the doctor-related factors? What are the health system-related factors? What are the things which can be done in order to improve the doctor-patient relationship? And we will conclude with it. So, first, let's see what is meant by medical sociology. The other name for medical sociology is health sociology. Medical sociology is nothing but the study of social causes and consequences of health and illnesses. The areas of focus under medical sociology are social determinants of health and diseases, social behavior of patients and healthcare providers, social functions of health organizations and institutions, social patterns of utilization of services, relationship of healthcare delivery system to other social institutions, and social policies towards health. So, though there are these many areas of interest under medical sociology, we are going to focus more on social behavior of patients and healthcare providers, which is closely related to our topic of doctor-patient relationship. When the social behavior of patients and healthcare providers is disturbed, then we get these kind of newses like we could see recently a doctor was book who was booked for death of pregnant women commit suicide. We could see articles showing the inefficiency or lacuna in healthcare delivery systems. We could see a doctor in Tamil Nadu recently suspended for negligence. We could see doctors from across the country is protesting against violence on doctors. So all these kind of news is clearly telling that the relationship between doctors and patients is not smooth, unlike the olden days. So, what are the reasons for this kind of strain? The reasons include commercialization, over medication, over specialization, heavy reliance on technology, decreased interaction with patient, lack of training in medical ethics, lack of communication skills, authoritarian behavior of the doctor, changing expectations of the patients, rising expectations of the patients, and faults in the healthcare delivery system. So when these kind of strains come together, it's going to result in mistrust, dissatisfaction, resentment, litigations against doctors and hospitals, assault on doctors, destruction of properties. So now here comes the importance of a good doctor-patient relationship. It was common before a few decades that doctors are considered as a part of patients' families, and they trusted the doctors to matters which is even beyond medicine. For example, they used to invite doctors to their family functions. They used to take their family decisions based on the opinion of doctors. So all these was happening few decades ago. But now the situation is completely changed. Very often, doctors are blamed for this faults in the system over which they have absolutely no control. One of the causal factors is the design of our healthcare services, which is a system which waits for people to get sick and come to the healthcare treatment rather than preventing the occurrence of the disease in the first place. The patients, the doctors, and the system all are responsible for this strain. What is the result? See, when you go to PubMed and search workplace and violence, you could see the number of paper is constantly increasing with 380 to 400 papers in the each in last 2 years. Okay, this clearly shows that there is increase in prevalence of number of attacks on doctors, and the reporting has also increased. You could comfortably assume that this reporting is highly undervalued, like it is a underreported statistics. But still, even though yearly around 400 articles are being published in PubMed index journals. Okay, so one of the articles presented like published by my seniors, it shows the study of workplace violence, its risk factors, its perceptions about workplace securities in doctors. It showed that the prevalence of workplace violence in the last 12 months during the time of study was 63.4 percentage, and in lifetime it is 78%, which means that 78% of doctors come across some form of violence in their lifetime, and out of this, 22% were demanded for extortion money, and 11.2% experienced intentional destruction of hospital property. Okay. Similarly, we could see another article from doctors of AIIMS Kalyani that patterns of workplace violence against doctors practicing modern medicine and the subsequent impact on patient care in India. You could see the results are almost the same. 77.3% of doctors have faced workplace violence. Out of this, 40% are due to actual or perceived non-improvement or deterioration of patient condition, and another 37% is due to perception of wrong treatment being given. So, all this is resulting in the loss of self-esteem of the treating doctor, feeling of shame, stress, depression, and anxiety amongst doctors. So what are doctors going to do? They simply refuse taking emergency cases. They refuse taking sick cases. They refuse handling sick cases, and they simply refer them to higher centers or order a higher investigation. So this is though doctors might be affected directly because of violence, indirectly it is going to hamper the healthcare delivery system, and patients would be at the loss. So, what are the factors improving doctor-patient relationship? We can broadly classify them into patient-related factors, doctors-related factors, and health system-related factors. When these three factors comes together, it's going to help in building a perfect doctor-patient relationship. First, we will discuss in detail about what are the patient-related factors. First one is the background of the patient. Role of the patient is mediated through social, economical, and cultural context within which the patient is based on. This context will shape his or her interaction with the institution and practitioners who provide care. The response of the patient and his or her ability to interact with the doctors is also shaped by various factors like the gender of the patient, the race of the patient, caste of the patient, the socio-economic class of the patient. All these things interact dynamically to shape social and economical access to care, thus influencing the patient's ability to continuously seek care. So, if a patient is coming to us, if a patient is coming to meet a doctor, there are multiple factors which are hindering it. Be the socioeconomic class of the patient. The patient might be very poor, that if he is coming to meet the doctor on a particular day, though the doctor is not charging any fees. For example, in case of government hospitals, though the institute or the doctors are not like charging any fees, the patient is still affected, still hesitant to approach due to economic reasons because he needs to leave his daily wages job that day. He needs to bring in few more people, one at least one attendant along with him. He need to pay for the travel. He need to spend for food for himself as well as to the accompanying person. And he might have some hesitation that he is belonging to a lower race or lower caste, and doctor might not treat me well. The system might not treat me well. So all these things will be going at the background of the patient before he actually approaches the doctor. So we should be considerate of these factors and address the patient appropriately so that the patient is comfortable in approaching us and talking to us. The second patient-related factors is the cultural context. So we are living in India, a culture where it is important not only to convince the patient but also to convince the family as well. For example, if you're advising an 80-year-old female with severe osteoarthritis to go for a total knee replacement, it is not essential to convince only the patient for the surgery, but you should convince the whole family. Only then the surgery will happen and the patient will get the benefit of the treatment. Hence, it is not important only it is important not only to build a good rapport with the patient, but also we should have a very good rapport with the family of the patient. The next patient-related factors is the reluctance to access to healthcare. Out of fear of judgment, the patient often do not disclose various kinds of efforts that they might have undergone in order to handle the problem that they are facing with. Sometimes doctors will exhibit insensitive behavior towards the patient, and this insensitive behavior will increase the reluctance of patients in accessing the healthcare. Next is the challenges in accessing healthcare. Transportation, loss of wages, expenditure on attendance, food, all these result in inappropriate treatment or inability to complete the proper treatment. So even if the poor patient bears all these costs, all these sufferings and comes to us, we are most of the times the treatment might not be a one visit thing. It may need follow up. But due to these restrictions, he cannot come to us for follow up, and we might think that this guy is not good, he's not compliant, he's not adhering to the medication, and we try to blame the patient. But the reality might be different. When we try to understand these kind of issues which the patient is facing, then we will be able to give them better solution and better patient care, and this will indeed result in a good doctor-patient relationship. So the next factor, patient-related factors, are overcrowding and waiting time. As a result of poor distribution of facilities and the flooding of tertiary care facilities, uh, the overworked doctors are barely able to spend time with the patients. The interaction is most of the time mechanical. So I am at AIIMS. If you come to our medicine OPD and see, you could see hundreds of patients standing in the long queue for a long time. In such case, it is not fair to expect a doctor to spend proper time in building the rapport with the patient, knowing about the background of the patient. No, it is not possible. All the focus of doctor will be in examining the patient, taking the short history, and diagnosing the patient and giving him appropriate treatment. So when this time is so limited, the overworked doctors will tend to keep their interaction as a very mechanical work. What is your problem? Okay, what are the clinical findings? Okay, this is the treatment. You take it, you will be fine. So these kind of interaction will never help in building a rapport. This will not help in building a trust between a doctor and the patient. The like they may not experience the comfort of ease that they require from an interaction which is meant to heal. In case of poor patient, this interaction becomes strained further by differences in the framework, the severe hardships that they had to undergo merely to physically approach the allopathic providers, and the paucity of money that results in the break in treatment might be misconstrued by doctors as defaulting. That is, the patient is not taking the medicines properly or not adhering to the instructions which we are giving. So, but we doctors might not be aware of these background factors, as I said, the socioeconomic status, the gender, the race, caste, all this we cannot be considerate if there is no sufficient interaction or sufficient time allotted in interacting with each patient. Hence, it is our responsibility to address this overcrowding and waiting time. More than a doctor's responsibility, it is the responsibility of the healthcare system. Because if these patients, if they are coming to AIIMS, if it means that they have some serious problems. So if they have been treated properly in the preliminary stage of disease, in the primary health center or in district hospital or in private clinics, they wouldn't have landed up in such complicated stage, and they wouldn't have come to AIIMS in first place. So the fault is not on the doctor sitting at AIIMS, but it is the lack of proper treatment at lower levels. So all these needs to be monitored by the competent authority in the healthcare system, so that overcrowding and burdening of doctors at tertiary centers might be reduced. Once this burden on tertiary care center hospital doctors is reduced, these doctors will be able to spend more time with the patients who are coming to higher centers, and this will help to build a better doctor-patient relationship and will increase the quality of care. Okay. So the next point is the expectations of the patient. A patient experiencing illness is a sufferer, and he expects to be cured and healed. The patient expects to be treated with care, sensitivity, and dignity, which are the cornerstones of the healing process. But in recent times, these expectations are not met, and the expectation is even rising. We should remember that, unlike in older times, where we were no longer dealing with uninformed patients, and these days we are dealing with patients who go for doctor shopping, who consults with multiple doctors, who refer to Google, those who even read PubMed and other scientific literature to know the latest treatment and come to us. So at times they might be even more updated than what we are, because the patient know what is his diagnosis and he knows what is the recent standard of care, which even we might not be aware. So we are not dealing with ignorant patients. We are dealing with sorry, we are dealing with well-informed patients. Okay. So because of this, and also the patient is giving money to us, so his expectations will obviously rise. Okay. When this ever increasing expectation is not met properly, it's going to hinder the doctor-patient relationship. The next factor is barriers in understanding doctors. Even despite of all these factors, if a patient approaches to a doctor, he may be unable to understand the doctor's explanation about their health conditions and the reasons for it being asked to follow certain regimens. To clearly say, if a patient is coming to what to say, if a patient is coming to AIIMS OPD and the doctor sitting in AIIMS OPD is someone from South India, he might not know Hindi properly. So language barrier might be there. Second thing, the doctor might be using technical terms, hi-fi terms, which might not be understandable by patients. Even if doctor is talking in normal terms, even that might not be sufficient in order to make the patient understand the picture completely. Like in my college, in my undergraduate college, our surgery professors used to draw in the case sheet and explain to patients. So those kind of steps, extra steps, should be made in order to make patients understand clearly what is the problem, what is the next step we are going to do, and how we can proceed further. So such kind of barriers in understanding doctors should be broken by active efforts from doctors' side, so that it's going to increase the complaints and help patients build trust on the doctors. Okay. Next, patient-related factors is patient often are the receiving end of insensitive behavior. Especially poor ones and women face discrimination by the healthcare workers. These poor people and women, they often have limited access to educational and economical resources. They are often at the receiving end of insensitive behavior and judgment by the medical professionals. Sometimes doctors stereotype them as, oh, this guy is uninformed, he's ignorant, and he considers patients to have irrational health approaches. This is ultimately going to affect the patients seeking health care. Okay. The next patient-related factor is the need for respect, dignity, and understanding. In addition to the technical competence and sound treatment, uh, our doctor should have an understanding about the need of the patient. That the patient needs respect, dignity, and understanding. Compare, you could see, like in villages and in other rural areas, if you compare the practice between an allopathy doctor and a quack or some alternative stream of medicine, they will have a roaring practice. Why is this possible? This is possible because those quacks might not have technical competence, but they are excellent communicators. Because of this very reason, their practice is much more better, and the patient trusts such kind of quacks more than they trust a qualified doctor. Okay, so in order to be a very good clinician, in order to be a very good doctor, we should be good communicators. We should understand the patient needs for respect, dignity, and treat them accordingly. The next patient-related factors is empathetic treatment. Sometimes patient might have undertaken some home remedies or alternative streams of medicine, but allopathic doctors usually consider that this is completely non-scientific, useless treatment, inefficacious treatment. Though this attitude of allopathic doctors might be technically correct, and we might even scold patients at times. But what is the result? This will have a definite bad psychological impact on the patient. Now, what will happen? Patient will stop revealing the details of the treatment, and this is ultimately going to affect the patient care. Next is the unregulated commercialization. Like commissions in drugs and diagnostic services has contributed to the increasing tendency of malpractice. This often leads to patients' dissatisfaction and may result in litigation to implicate the doctors for errors that may be real or imagined. All these increases the suspicion of the doctors. If a patient is seeing that in my OPD, like I am always surrounded by five medical reps, I am surrounded by diagnostics people. They're giving me they're giving me parties, they are sponsoring my foreign tours. If patients are saying this, what will happen? Patients will automatically think that, okay, this doctor is giving me unnecessary drugs, unnecessary investigations, and he's taking the benefits out from the pharma companies. So he's not a good doctor. He's not interested in us as a human being or a patient. Rather than he's seeing us as a commercial material and he's trying to extract money out of it. So such kind of unregulated commercializations should not should be appropriately addressed, and the image about this image of doctor, yeah, we can give a countdown.
5, 4, 3, 2, 1.
So the next factor is unregulated commercialization. Like commission in drugs and diagnostic services has contributed to the increasing tendency of malpractice. This often leads to patient dissatisfaction and might result in litigations to implicate the doctors for errors which might be even real or imagined as well. So all these increases the suspicion on doctors, thus affecting the doctor-patient relationship. Imagine a busy practitioner who is always surrounded by 4 or 5 medical reps and people from CT and X-ray centers. You will think that okay, this guy is taking commissions from all of them, and because of this he's writing me a CT for even a simple headache. He's writing me 10 drugs, 20 drugs at a stretch. So such kind of impression is built in the patient's mind. It might be true or it might not be true, but whatever it is, when this type of mindset is there for patients, it is going to decrease the trust which they have on us as doctors. So we should try to address this. We should try to break this mindset or image of the doctors when it comes to unregulated commercialization. So steps should be taken in order to regulate these kind of activities. The next patient-related factors is out-of-pocket expenditure. Studies have shown that the private expenditure exceeds 65% of the total expenditure on healthcare in countries like Bangladesh, India, Indonesia, Myanmar, etc. Out of this, out-of-pocket expenditure constitutes about three-fourths of the total expenses. This puts in healthcare out of reach for a large proportion of patients, especially in countries like India. Inpatient healthcare, the expenditures for this inpatient healthcare are known to be among the leading cause of deaths for rural population in countries like India. Cost of care is also increasing due to over specialization and the inappropriate use of drugs and diagnostic services and the aggressive intrusion of pharma companies into healthcare industry. For example, you could see if someone is having a headache, he won't go to a family physician, he won't go to a general physician, he will directly land up to a neurologist. Neurologist will directly say, take a CT and come, take a MRI and come. So all this is going to increase the out-of-pocket expenditure, which is nothing but how much money the patient is paying out of its own pocket, which is not covered by any insurance. Okay, you could see that a study in Haryana district has shown that a study in Haryana district has shown that the average out-of-pocket expenditure for OPD consultation is around 1,000 rupees, and for IPD consultation is around 22,500. So it also shows that the mean per capita out-of-pocket expenditure for OP consultation is around 500 is around 85 rupees, which ranged from up to 595 to 29 rupees in different districts of Haryana. A similar figure, a broader picture, you could see that the World Bank has released this data showing that 55% of the expenditure, healthcare expenditure in India is out-of-pocket expenditure, which means that if 100 rupees is being spent for healthcare in India, out of this 100 rupees, 55 rupees, more than half of it is directly from patients' pocket. So this is going to increase the financial burden on patients. If you compare those with the other parts of the world, like UK, it is 17.7%. If you take US, it is around 11.3%. Take the globe as a whole, the world average is just 18%. India, it is around 55%. Okay, so this is the burden which healthcare is imposing on the patients. Okay, so you can see that government is launching wonderful policies like Ayushman Bharat, where around 5 lakh rupees per family per year is given as insurance by the government. But despite that, 55% is out of pocket expenditure. What does it say? This clearly says that patients are not aware of the schemes. Patients are not taking the full benefit of the scheme. So as doctors and as like people of healthcare, we should work towards sensitizing the doctors in order to in sensitizing the patients in order to make them get aware about these kind of various insurance and subsidies which government is giving for the patient care. Okay. Next, we have completed the doctor-related factors. We'll move patient-related factors. We'll move to the doctor-related factors. So, for the sake of convenience, I'm broadly classifying the factors. There are around 20 factors. I'll classify it into three broad categories: pre-interaction with the patient, during interaction with the patient, and post-interaction with the patient. So, this is not a standard classification given by any guidelines. This is just for the sake of making you understand and remember things better. So first, pre-interaction with the patient. So first, the aptitude of medical aspirants we need to discuss. So how do we enter medical college? We give NEET UG examinations, and then after which we get a MBBS seat and we become doctors. But this exam is a MCQ exam, which is going to assess the knowledge of medical aspirants. It is not going to assess the aptitude of medical aspirants. So whether a person is empathetic towards the other fellow human being, is he a patient listener? What are the soft skills which he possesses? None of these is assessed in these NEET UG examinations. Because of this, a patient who is not so socially connected, or like who is not having empathy towards patients, might become doctors, and we don't know how much good doctor he'll become. And this is going, he might be technically very competent, but he might not have a proper interaction with the patient, and he might because of this he might not be able to build a good doctor patient relationship. So this factor, this aptitude of medical aspirants, we should try to test in some way or the other, so that this it will serve as a filtering process which provides better doctors for the future of the country. Next thing is the foundation course for MBBS. While I joined MBBS in 2014, I was taken to dissection hall on day one. I started dissecting cadavers on day one. On day 15, they told you are going to start having exams from you are going to start having internals. So we need to complete the portion. Like that, we were having some kind of timeline for completing the portions, giving the examinations, and getting out as doctors. But way down the line, in 3 years after I joined MBBS, my 17 batch juniors, they started having something called foundation course, where for one complete month they will be taught about soft skills, they'll be taught about medical ethics, management, all these things. So this gives them a better orientation rather than running behind marks and completing the curriculum. These kind of foundation courses for MBBS students is very helpful in order to make them a better doctors in the future. So on paper, this is there in all colleges, but few colleges don't take it seriously and they don't implement it seriously. Once medical council and other competent authority is making sure that such kind of foundation course is happening regularly for MBBS students, that's going to help in getting better doctors for the country. Okay. So the next doctorated factors is course on ethics. It is a recommendation from the World Health Organization that teaching ethics for medical students is essential. Even there is a wing of UNESCO called UNESCO Chair in Bioethics, who is doing a wonderful job of spreading knowledge about bioethics across the globe. I'm proud to say that even I'm the Nodal Center President for Students Wing of UNESCO Chair in Bioethics. We have been doing a lot of awareness programs in order to sensitize the medical students and the general public as well about the medical ethics, what is meant by bioethics, and various different aspects of it. So, such kind of initiatives promoting ethics should be encouraged, and all medical councils should take interest in implementing teaching of ethics and assessment of the same. The next doctorated factor is medical sociology. I do not remember coming across a term called medical sociology during my MBBS, but active efforts should be taken to include this medical sociology in curriculum. This will create in medical students the respect for patients, and this will inculcate the spirit of equality in his or her relationship with the patient. Many times, the greatest fear of the patient is that if I go to doctor and if I tell that I took some non-allopathic medicine, or if I'm not following his medication advice properly, he might scold him. Even without me doing a mistake, he might scold him, and I might be feeling ashamed in front of others. So these kind of fears patients have even if they are going to a doctor for a first time. If under such vulnerable conditions, if we are not kind to them, if we are not so receptive to them, then the psychological impact which this has on the patients is immense. Hence, we should always greet them with a smile. We should try to be kind to them as much as possible, and we should listen to them as much as possible. Teaching medical sociology right from the early stages would help students under the social aspects of medicine. Even I see this initiative by Medisage in order to encourage this topic as a lecture is a very noble one, because this is going to increase the awareness about this topic of doctor-patient relationship and medical sociology. So if someone who's watching this video, if he's taking at least one or two takeaway points from the whole 30 to 40 minutes video, it's ultimately going to help some patients someday or the other. So the purpose of this lecture is to facilitate doctors who are seeing this to become at least 0.1% better doctors whom they actually are. We all know that no one is 100% perfect. There is always scope for improvement. So such initiatives in promoting doctor-patient relationships and these kind of soft skills is going to benefit the doctors as well as the patients in a long run.